Hello, good afternoon. My name is Edgar Tay, and welcome to this ACC Singapore chapter webinar. Today, we're going to talk about onco-cardiology, a very interesting topic, as all of you are aware. And the subtopic is optimizing cardiac outcomes for our cancer patients. So as you know, this talk and webinar is our third in a series of our quarterly webinars, and is endorsed by the Singapore Cardiac Society. And we're also very happy and thankful that this has been sponsored by Philips as well. So let's go to the next slide, please. So today, I'm very delighted to co-chair this session with Professor Po Kian Keong. And we also have a great bunch of speakers today. We have Dr. Eric Young, who is really helping us a lot because it's really late for him. And thanks, Eric, for joining us. He's the head of UCLA Cardio-Oncology program at the Ronald Reagan UCLA Medical Center. We also have Dr. John Chia, a good friend and classmate of mine. He's an oncologist at Curie Oncology at Mount Elizabeth Novena Specialty Center. And Dr. Juan Lopez Mate, he's also a cardiologist, but today he's unable to join us, so he's going to send his slides to us, and he'll be giving us a video of his talk today. We also have a great bunch of panelists, and feel free during this period of time to ask them any questions. We have our cardiologists with us, Dr. Ching Min Dr. Chuang Xuan Hong, Dr. Tan Li Ling. We also have Dr. Chong Jun Hua. All of these are very seasoned in this field of oncocardiology. And we also have our oncologists, Dr. Benjamin Chua, Dr. Richard Quek, and we also have Dr. Francis Chin, who is a radiation oncologist. And with this outstanding panel, I think we will have lots of discussion today. Next slide, please. So for those who are attending this session, as you know, you can apply for your CME and CPE points once you've attended this session. And at the end, for those who want a certificate, there will be a QR code that will be flashed out, and you can, at the end of the talk, just scan this code and have your certificate printed, or you can get this through your email subsequently. Most importantly is, as you know, these webinars are not just for the content, but also the ability to be very active in terms of Q&A. So we want to actually have as much interaction as possible. As you know, this is a very important topic, becoming more and more important. And this is a great opportunity, and it's one of our first time we have so many oncologists and a variety of subspecialists here. So feel free to use the Q&A button and ask your questions. And we will have our moderators, Dr. Tan Li Ling will be also moderating the Q&A session. And yeah, put her in a hot seat and ask as many things as you want, and we will try to answer to the best of our ability. So without further ado, I'll let my co-chair, Prof. Po Kian Keong, to introduce the speakers. KK, you're on mute, I think.
Thank you, Dr. Tay. I'll just put out a couple of slides. I'm starting off by showing this American College of Cardiology, the ACC-AIG, which I'm the chair for these 2 years. We are all over the world. There are 42 international chapters together with more than 15,000 members. And we organize a variety of educational initiatives, and one of them is the ACC Asia, one of the 3 to 4 regional conferences that we organize over the year. ACC Asia is well organized in Singapore with the Singapore Cardiac Society, and Dr. Edgar Tay is very, very kind to organize additional educational symposium to supplement the regional conference. And we have over 100 such educational symposium over the entire of last year. So Dr. Tay has brought up the ACC Singapore chapter, which is under the Singapore Cardiac Society, to distinguish tier. is the current chapter governor, and he has organized symposiums such as tricuspid regurgitation, lipids, state of the arts, and now, very interestingly, Onco-Cardiology. How can we optimize cardiac outcome for our cancer patient? Some of this are available in the NCD Academy, which is an app which you can download for free. It look at non-communicable diseases. It's an educational app. So that includes cancer as well as cardiovascular disease. Being the top cause of mortality in Singapore and also globally, both cardiovascular disease and oncology, we are really very pleased to have this symposium, which is supported by Philips. I would also like to pay tribute to my greatest mentor who would be here to attend this if he's around. Prof. Chabonok is man that makes most difference to my career, and he is a legend in cardiology, and he would be very interested to attend this particular symposium, especially if his son is also speaking here. So let me just start off by introducing the first speaker. Professor Eric Young is Associate Professor of Medicine, Director of UCLA Cardio-Oncology Program. He's also Associate Program Director for Cardiovascular Fellowship, and his clinical and research interests include valvular disease, multi-modality imaging, echo, and cardio-oncology. So today he's going to speak on what is exactly is cardio-onco or onco-cardio, and how to actually optimize outcome for cancer patients. Without further ado, can we invite Professor Young, please?
Thank you so much, Dr. Kyung and Dr. Tay, for that very kind introduction, and for really the huge privilege and honor to present my talk, and really one of my passions to your audience. And I also would like to thank the Singapore Cardiac Society and the ACC chapter for extending this invitation. And as I said before we started, I would love to come and visit your country again. I've been to Singapore 3 times in my life, and I miss the sights and the night markets, and it's just an amazing place, and arguably the best food probably in the whole region. So I will stop talking about that and talk about in a brief time that I have. Again, what is this field that, in a nutshell? And I think this field would not be possible without really the amazing advances made in the cancer field. And really, I'm very happy to see so many oncologists in the audience. It's a very impressive showing here, this webinar today. Because of the advances and the long and much improved survival rates of cancer patients, probably not just in Singapore, but in the US and in the world, really cardiovascular disease, again, is really an utmost importance to maintain for these patients, both during treatments and after, depending on their prognosis. And really what my goal is to educate the audience on really some core high yield things that one can do to evaluate and do appropriate surveillance for cardiotoxicity for these patients, many of which may live many years, if not be cured, and eventually have cardiovascular disease be the top cause of morbidity and mortality in this group. So I'll begin, and I'll do my best to be brief and high yield and succinct, but here are my disclosures. So I will divide my talk into several sections. One, the state of cancer and why the field now matters. And also going to the core question, well, what is the purpose of our field? Why do we do it now, and why is it important? And although there's so many agents I could go over, I want to talk about how we define cardiotoxicity in the context of this talk, focus on cardiomyopathy or left ventricular dysfunction. And really also for people who want to know, well, what can we do from an interventional standpoint? What are things we can do medically to either attenuate or treat, people who have suffered cardiotoxicity or those who are vulnerable? And finally, to touch upon really one of the game-changing agents in the cancer arena, which many of you know is immunotherapy, which has provided not only really new survival opportunities and benefits for high risk or very serious diseases such as lung cancer, melanoma, and GU cancers, but also at the same time a potentially new disease process. So Moving on to why, how cancer is doing and why cardio-oncology now matters. As many of you are cardiologists, I'm not going to belabor these statistics, but it's interesting. When I was looking at Singapore's, health statistics, the top cause of death, as you will see, is actually cancer, at least as of 2018. That's what the Ministry of Health, reports. In the United States, by far, it's still cardiovascular disease. It is a top cause of death of both men and women, especially in women above 65 years of age. And as Dr. Keong alluded to, it is a global cause of death. But for us, it kills more people than cancer and lung disease combined. Moving over to cancer, however, you could see overall that death rates, and I imagine the same similar trend is seen in Singapore, is that for many cancers, for both men and women, overall death rates have been going down since the 1990s due to advances in treatments. And you can see here also that there tends to be a downward overall decrease because of treatments. But at the same time, the reason why I bring this up is that as cancer patients live longer or have more survivors, cardiologists are going to be seeing a lot of these survivors in their clinics, and many of them already take care of these patients. But the bigger question is, well, what are the treatments that they received could cause problems for them in the future? Or even you may be taking care of people with active cancer like breast cancer, which has at 5 years over a 90% survival rate if you have stage 3 or below. And really, it used to be people would be like, oh, you have cancer, just eat whatever you want, just take it easy, things like that. But if you're going to survive many of these kinds of cancers, you really should be aggressive long-term in maintaining your cardiovascular health and risk factors. In the United States, this is going to be a big number. In about a decade, in 2030, there's going to be overestimated 20 million Americans alive with, with a history of cancer, if not recently treated or cured of cancer. And I had to do a little research on my end before giving this talk, and going over to the Ministry of Health statistics here is that, interestingly, the principal cause of death is cancer, with ischemic heart diseases being number 3. So a very superficial extrapolation is you're doing a much better job than we are of taking care of heart disease. But I would say that this is obviously 2 major risk factors that interplay with each other. And going over the cancer registry from 2018. And some of the drugs that I'm going to go over really have a lot of relevance to this, is that the highest incidence for men is colorectal cancer, but the highest cause of cancer death is lung disease, which it is for us. And for women, it is the breast cancer is still the highest incidence and the top cause of death. And some of the agents that we are really historically known for using are really well known for also their cardiotoxicity risk. However, again, as I alluded to, if you survive breast cancer, and at least for another 10 years, United States studies of our registry shows that the more likely you're going to die of heart disease instead of recurrent breast cancer. And that's what our breast oncologists tell our patients. I said, when they're cured or in remission, obviously they're worried about having cancer again. And they say, no, you're probably going to die of a heart attack. And that's actually what they tell our patients, and they put it in our field. And then the big question then is, well, why does it have to get to that point? Why should we, if we know they're going to likely survive, then we should really be aggressive in maintaining their cardiovascular disease health. And in cancer survivors, like I said, 2/3 of adults with cancer in the United States will be alive in 5 years. 3/4 of children diagnosed with cancer will be alive in 10 years. And many people will have chemo and or radiation with the potential for long-term cardiotoxicity. And Dr. Lopez Mateo will talk about the radiation effects. And also the risk of cardiac death in many patients is actually higher than the risk of cancer recurrence. And if you compare, at least in the United States, to sibling controls, people with a history of chemo radiation are probably 7 times higher, more likely to die early, 15 times higher to have heart failure, 10 times higher to have premature heart disease, and 9 times higher of developing stroke. So that, again, is why cancer matters to the cardiology field, and this is where we come in. And here in my program, we use the word cardio-oncology. I know in Texas at MD Anderson, Onco-Cardiology is used. It's kind of, however, it's tomato, as we say in the United States, however you want to say it. But really the philosophical approach and purpose of the field is really trying to understand the mechanistic overlap of 3 major factors. 1, a patient's individual cardiovascular risk factors profile, the diagnosis of the patient's cancer biology and disease, and subsequently the overlap of the cancer treatments they may have received in the past or what they are currently getting. And finally, this overlap of toxicity, both acutely and chronically, all of which can be impactful for them for years to come. And the thing about this is that what makes this such a daunting but exciting field is that for every patient, every different kind of cancer, This Venn diagram really just rotates and is very dynamic. And it's our job to really understand how much overlap there is for each kind of cancer in each individual. And because we are still relatively lacking in evidence-based big randomized controlled trials, ultimately it still ends up being a very personalized experience of ongoing risk-benefit discussions with the cancer patient, their loved ones, their multidisciplinary cancer team, and really it is really truly rewarding experience to be able to get them not through just cardiac disease, but also their cancer treatments, so they can hopefully, do this. Whereas in an earlier era, it would be like, oh, you're too sick for both. You're getting cardiotoxic. We got to stop everything. And really, for many cases, we should be able to control cardiovascular risk factors. In the United States, this is a very old graph, frankly. This is actually probably outdated, but really cardio-oncology has really exploded in the United States here. And services have doubled since 2014. And in training programs, where I also run as associate program director, is incorporated cardio-oncology in our core curriculum. So moving on to cardiotoxicity and definitions, and really focusing on some historical agents. I don't have a lot of time, but I want to focus on really one aspect of cardiotoxicity, which many of you know as LV dysfunction. I'm not going to belabor these numbers. Really, it's I just want to emphasize the reason why this slide is frankly inaccurate. Our oncology colleagues use this as a way of their clinical trials of determining cardiotoxicity. This really just demonstrates really how poor of an understanding we have about cardiotoxicity and why it occurs. If we are defining it by an ejection fraction, I would argue that if the EF is already looking like this, or if they've already developed heart failure, whatever degree of cardiotoxicity is, it's already quite severe and quite advanced, and it may not reverse for that matter. And I think for that matter, we need to really define better techniques such as subclinical speckle tracking, biomarkers, other things that we can do to detect subclinical dysfunction before it even occurs. But I don't have a lot of time, so I'm going to focus on really two of the major sort of agents that many of you are familiar with that are used in breast cancer, lymphomas, leukemias, and also with anti-HER2 treatments, which of note was developed at UCLA by Dr. Denny Slayman's lab here, also used in a variety of gastric cancers and HER2 positive malignancies as a whole. And why cardiotoxicity occurs, at least in a general overall sense, is that, well, we think that one, you have multiple hits. You come into with a cancer diagnosis if you're already older and you have pre-existing risk factors like hypertension, diabetes, or coronary artery disease. And the treatments themselves both cause direct and indirect effects on your cardiovascular reserve. Subsequently, what happens when you get chemotherapy and radiation? You get sicker. You're told to eat whatever you want because you don't want to lose weight. You go into renal failure, you get dehydrated. The medications and statins and blood pressure medicines you normally would use, you can't take. So, and you can't exercise as much. So all of these things on top of direct toxic effects that these agents have may eventually contribute to overall early and long-standing cardiovascular, detrimental effects. Moving over to anthracycline cardiotoxicity, this is, I think I showed this slide mainly to illustrate a major point that is that really, when does anthracycline cardiotoxicity occur? Because I know anthracyclines are commonly used in a variety of settings, not just breast cancer, but lymphomas, a lot of hematologic malignancies, and sarcomas. And really, ultimately, this landmark study showed in a retrospective fashion that most ejection fractions drop within a year of treatment. So it's after treatment. So as cardiologists, if you're taking care of these patients, I know in the United States, our oncologists don't always check after treatments. They may check during treatments, but they don't check afterwards. And that's actually a majority of when the ejection fractions drop, and many of them may be asymptomatic. And if you're able to look at this graph very carefully, even with goal-directed medical therapy, even if you initiate beta blockers and ACE inhibitors very quickly, the ejection fraction never truly entirely recovers. And this actually fits what I see in clinical practice. And frankly, we don't know what this means. A lot of them have these low normal ejection fractions long-term and for life. And we still need more data on that. And also trastuzumab, or Herceptin here in the United States, although it is deemed a quote unquote reversible agent once you start getting ejection fraction, EF decline, actually it shows many other, retrospective studies in Europe have shown that it can still lead to long-standing heart failure with or without anthracyclines. Just the presence of it can increase your hazard ratio for that. So we still have a lot to understand about really who is at vulnerable for long-term and immediate heart failure. But just to show that a lot of these agents can be quite, I guess you could say, very difficult to truly predict their trajectory and risk. But I would say the clinical really high yield lesson I want to convey to the audience is that, again, in order to look for cardiotoxicity, you want to identify the drugs that are at risk. And I would say that I disagree with the type 1, type 2 toxicity, paradigm that the ASC uses, and really replace it with anthracycline-based regimens or anti-HER2-based regimens. And if you're going to be exposed with someone with anthracyclines, again, it's always good to get a baseline ejection fraction assessment at the end of treatment and then 6 months later. If you want to provide more of a refined approach, biomarkers such as troponins and global longitudinal strain assessments can also be ideal. But if the ejection fraction already drops during this time, it's important to refer them to a cardio-oncologist. And also another thing that's important, especially the oncology audience, is the high-risk cutoff now is deemed 240 milligrams per meter squared of doxorubicin equivalent. So that's also very important because many people historically thought it was a lot higher. There's technically no safe dose, but that's considered the higher end. It's even lower if you get chest radiation, right? If you add anti-HER2, if you're getting anti-HER2 treatments by themselves, you assess LVF every 3 months. But if you are combining it with adjuvant anthracycline therapy, you need to also check at the end of treatment and then within 6 months. So moving over to cardioprotective strategies, right? Also, sometimes you see these patients when their ejection fraction is already dropped or they developed heart failure. Really what's important here. And really, I demonstrate this as a very unfortunate example of a young woman in her 20s who received idarubicin for acute leukemia. And I know it may be hard to see, but ejection fraction dropped to less than 20% after 2 to 3 months. We had no idea why. There's no high risk features, but we have to stop treatments. And really, what kind of agents can be effective in potentially mitigating or attenuating risk? First, the medication that I want to talk about is something that most cardiologists will have never heard of, is dexaroxazine, right? And interestingly, this is a drug that really actually has the most robust evidence in actually lowering the risk of heart failure in breast cancer as well as other lymphomas, also in the pediatric population. It reverses the mechanisms associated with anthracycline-induced cardiotoxicity, but at least in the United States, it actually has a very narrow indication or on-label use for really high doses of anthracyclines. There are some concerns for secondary malignancies in children, but most of us don't believe that really exists anymore with recent data. But you can see with the meta-analysis on the right that a lot of it tends to go towards favoring dexaroxazine in preventing heart failure with anthracyclines. But the problem is, once again, is that we really don't know who benefits from this approach and who is which are the vulnerable patients. And amongst some of the recent randomized controlled trials looking at cardioprotection is in addressing the question, well, should we just treat everybody with beta blockers and ACE inhibitors? These trials I felt were very important in answering that question. So the CC trial looked at HER2 negative breast cancer patients, a young low risk population in Brazil, and they looked at patients randomized to carvedilol versus placebo. And essentially, they've looked at the incidence of a lower ejection fraction of 10%, and they found that there was no statistical significant difference between the carvedilol and placebo group. Interestingly, there was a higher troponin I level in the placebo group, which we still don't know really what that means. But interestingly, just using carvedilol as just a shotgun approach was not clinically useful in lowering the incidence of LVEF decline. Now, moving on to trastuzumab related or HER2 positive cardiotoxicity, looking at Dr. Guglin's study, they looked at carvedilol and lisinopril versus placebo, or one of those two arms. And they also looked at two separate groups. While the overall group did not show a benefit between the two, if you separated analysis of patients who received anthracyclines versus those who did not as part of their chemo regimen, anthracyclines and trastuzumab was associated actually with a protective effect using carvedilol with lisinopril. So to me, both these trials were game-changing in the sense that while these were simple findings, I felt that people that were getting higher risk treatment regimens may benefit from cardioprotection if they can tolerate these medications. And I've noticed this study was not powered to look at a difference between carvedilol and lisinopril. But if you look at the overall data as a whole, the cumulative benefits is really kind of disappointing. But at the same time, these studies are very small in nature, and also, a lot of heterogeneity. And also, I think we're still have yet to look at really higher risk populations to determine who benefits from cardioprotective strategies. And finally, I want to touch upon really the big game-changing drug that many of you are aware about. And if it's like in Singapore and the United States, this is now used in a variety of cancers now. Immunotherapy or immune checkpoint inhibitor therapies. This is really, an agent that has allowed, the ability of the patient's own innate immune systems to really finally, find, the tumor cells that use defense systems to evade the immune system by interfering with the PD-L1 ligand system as well as CTLA-4s to be able to have the T cells recognize and frankly kill the tumor cells that affect these patients that usually evade other traditional therapies. And this is a nice illustration by Tony Rebus at UCLA, who helped develop pembrolizumab. However, at the same time, when the immune system attacks a tumor cell, in certain organs, it will also attack healthy tissues in some cases. And again, we have now a new disease process known as ICI-associated myocarditis, which can become fulminant. We don't know the true incidence. We think it's at least 1%, but it really has gone over, we think that at least 40% of the US population could be eligible for immunotherapy at some point with cancer. And so subsequently, the absolute number will go up. And really, T cell infiltration can occur all parts of the heart, in the vasculature. And also why it is so concerning is one, clinically, it can be very, very elusive. People present with very nonspecific symptoms of heart failure, chest pain. It can simulate acute coronary syndrome. And usually the medium of onset occurs usually on median about 27 days after the first treatment. And many of you know that this can be every 2 weeks, every 4 weeks. And it can occur months after starting therapy. And this is all data from the immune checkpoint inhibitor myocarditis registry, of which UCLA is part of, led by Tom Nealon at Massachusetts General Hospital. ECGs can be abnormal, but they're very nonspecific. A normal echo is not reassuring. In fact, it can be normal in over half of patients. Really, the biomarker that is the most high yield is probably a troponin assay, signifying cardiac inflammation and necrosis. It's elevated in most cases. And also, if not caught late, if caught early, if it's not caught in time, it is a high mortality, anywhere probably ranging from 40 to 50%. And the earlier you initiate steroids, immunosuppression, the lower event rates that they have. And also, if your ejection fraction is abnormal at the time, complete recovery was seen in about maybe half of these patients. One particularly dramatic case that we had here at UCLA was a woman who had colorectal cancer, who had 3 cycles of nivolumab, presenting with this really bizarre fascicular alternating ventricular tachycardia. I will tell you that, I love ECGs myself, and I think immune checkpoint inhibitor myocarditis has some of the most bizarre rhythms I've ever seen. And this patient eventually needed Impella and via ECMO support. The biopsy here confirming diffuse lymphocytic infiltration, and subsequently actually survived and is still following with me in my clinic today and in remission. So, what I talked about is really the tip of the iceberg. Really, internationally, there's been over 60 cancer drugs launched within the past 5 years. Global spending has increased to over $133 billion, and more than 240 medicines and vaccines were developed. And really, this is just a class, again, this is why I said the tip of the iceberg of everything else we are talking about, other cardiotoxic properties. So in summary, advances in cancer therapy have really led to really, significant increases in long-term survivals. And this is a special population that we should really pay attention to and provide aggressive cardiovascular screening and treatment. Traditional heart failure medications and dexamethasone may have some protective effects, but again, a shotgun approach probably is not going to be the best thing for them, especially in lowest populations. I think immunotherapy for the cardiologists and oncologists is growing rapidly in use and can be associated with a rare form of fulminant myocarditis, can be fatal if not immediately treated with immunosuppression. As an academic, I feel that it is a young, ripe field that's really an exciting opportunity for basic scientists and clinicians to turn it from a reactionary science to a preventative science. And really what I also enjoy about this field is really the multidisciplinary aspect of this, and collaboration and communication with our cancer colleagues to provide optimal cardiovascular care and surveillance before, during, after, and way after cancer treatments with therapies. And again, with the COVID-19 pandemic, really how our field's going to be is also a topic of concern. And, given how big UCLA Health is, this would not be possible without all my collaborators and colleagues and fellows who have demonstrated interest in the field and have, helped us with all these centers. And I would like to thank everyone. And again, I apologize for running over a little bit, and I'm happy to take any questions at the end. Thank you very much.
Thank you very much, Professor Yang, for such a nice talk, providing a helicopter view and also putting the entire field perspective. There are some questions, but we'll leave it to the end. So let me introduce the second speaker, who's Professor John Chia. He is an oncologist from Curie Oncology, Mount Elizabeth Novena Specialist Center, He's an expert and a clinician scientist in immunotherapy, which is really hot. And he subspecialized in gynae oncology, breast, and colorectal cancer management. He's going to give us his wish list in terms of breast cancer and the heart. So without further ado, John, please.
Thanks, KK, and thanks, Edgar, for this wonderful privilege information. Today I was asked to give a short perspective of from a medical oncologist point of view, and as KK says, to present a wish list. So as Eric said, that our cancer patients are living longer, and we are moving towards being very concerned about late stage toxicity, especially for women with stage 1 and stage 2 breast cancers, which are highly curable. Eric mentioned a lot about anthracyclines and HER2-directed therapies. I thought I would talk a little bit more about this other new class of agents that we're using for breast cancer, which is CDK4/6 inhibitors, which can prolong the QT interval. So this is an example of some of our patients. This is a middle-aged lady. I mean, she presented with a metastatic breast cancer. This is after 6 cycles of Herceptin-based chemotherapy, Taxol carboplatin. And then after that, she was consolidated with another 6 cycles of anthracyclines, FAC. So double hit HER2 plus anthracyclines. Tumor went into complete remission. 10 years out, she's still no evaluable disease. Lung metastases have disappeared. Below panel is another patient, a young girl who's actually a nurse, visceral crisis. She was treated with a double HER2 combination therapy, pertuzumab plus Herceptin. Her markers dropped from 5,000 to 50, and she remains completely well. So the question is, this chemotherapy is effective, but how do we manage the toxicities? How do we correctively identify the patients, stratify patients for risk? How do we monitor risk and mitigate the risk? For anthracyclines, we know that the standard dose for breast cancer is doxorubicin cycle for times 4 cycles. That will give you to the limit of 240. Sometimes for some locally advanced breast cancer patients, we give 6 cycles, and that will take you to 300. That's when things get dicey. The patients that we really worry quite a lot about are people with sarcomas. And for some sarcoma regimens, we can go to pretty high doses. So anthracycline is completely dose dependent in terms of their cardiomyopathy risk. We worry a lot about patients with cardiac disease, and we often find substitutes instead of anthracyclines. Diabetes is important. In the past 20 years, I've had 3 patients with cardiomyopathy with AC, and one of them, actually 2 of them were diabetics with poorly controlled diabetes. We tend to worry a lot about patients who are elderly. I don't treat children, but children are very, very sensitive to the long-term effects of anthracyclines. Echo is mandatory in anybody over 40 years old. The mechanisms of cardiac dysfunctions are very complex. They converge on reactive oxygen species, double-stranded DNA breaks in the myocardium, mitochondrial dysfunctions, and impairment of mitochondrial biogenesis. Direxosine is something that people talk about, but it's almost never used in the clinic. The FDA has only approved direxosine in combination with anthracyclines for people who go for their second round of doxorubicin therapy after they hit a limit of 300. Most of the time, we find alternatives. There's always a fear that while direxosine may be effective, they may actually interfere with chemo dysfunction. Eric presented a randomized control trial of carbidopa. This was one of the early studies that started up the whole ball rolling. And this shows the 2 cohorts. It was a randomized double-blind placebo-controlled trial. For the control cohort, they had actually a drop in their EF level after chemotherapy, whereas the group that had carbidopa actually maintained. This wasn't shown in Eric's phase 3 study, but if you ask for an oncologist perspective, if I were the patient receiving it, if provided there's no downside, I think there'll be limited. I would just, given the limited side effects of beta blockers, if my blood pressure can tolerate it, I would definitely want to get carbidopa. In the absence of very, very strong cardiac protective measures, monitoring becomes very, very important so that you can intervene early. As Eric said, that LVEF is really not sensitive enough. We do this all the time, and we in some ways fool ourselves thinking that everything is okay. But the drop in LVEF occurs actually very late. It occurs in the late stages, and when the disease is irreversible. There's been a great movement towards looking at global longitudinal strain instead of just a simple measure of LVEF. I'm not a cardiologist, not really qualified to talk about it, but there's been quite a lot of literature on it. If you look at, this was one of the early studies by Saiwaya, where he showed that LVEF by the normal two-dimensional echo and pro-BNP did not predict for cardiotoxicity at all. But actually, if you looked at longitudinal strain and high sensitive troponin I at 3 months, they were very strongly predictive of cardiotoxicity at 6 months. And this was also shown out in other studies where the global longitudinal strain score more than 15% is likely to predict very bad, to predict impaired outcomes. And early detection is very, very important. I only have one slide for her too. Suffice to say that right now, oncology is facing an embarrassment of riches. There are so many of these drugs. We're using it in the clinic every day. Many of them are highly effective. We're using it in combinations as well. For example, tucatinib together with herceptin, TDM1, sometimes with other HER2 combinations. So HER2 is a central player in this. We use agents which are monoclonal antibodies as well as small molecules inhibitor which block the downstream signaling pathway. I just wanted to make one point. I don't know whether I will eat my words, but as medical oncologists, we're not so worried about HER2. The average incidence of CCF is only about 1%, not more than 2%. Almost invariably, it's reversible. We never know what will happen 20 years, 30 years down the line. Maybe these patients have a higher risk of getting congestive cardiac failure, as Eric's study showed, eightfold or twofold long-term risk in long-term heart disease. But so far, we've never had any problems with this in the clinic. The EF can drop, in the short term to 20%. You follow them up, it goes back to normal over time. So it's something that we monitor for, but we're not as worried as compared to anthracyclines. And then finally, for the last class of agents, I just wanted to talk a little bit about ribociclib. This is a CDK4/6 inhibitor. It's a cell cycle inhibitor. It's an oral tablet drug. It's highly effective. So this is a patient who has NQRAS breast cancer, pleural effusion. This is after 3 months of therapy. This picture is just taken just a week ago. Her pleural effusion completely resolved. So this is a really nice drug to use, very sweet, but it's toxic in terms of QTC. Every time we prescribe it, we worry whether the patient will drop dead. In the trials, they excluded people who had baseline ECG QTC more than 450 milliseconds. In the protocol, you're supposed to check at day 0, day 14, day 28, day 42. It's a big headache. You're supposed to check electrolytes every cycle. There are alternatives like palbociclib, abemaciclib, which have a less QT prolongation. But when you use ribociclib, you just have to be really, really careful. We are mostly worried about the third hit when patients were on these tablets, ribociclib, for years, and then one day they get a flu, they go and see their GP, and the GP gives them Clasit, and then they drop it. And this has happened before. It's been reported in literature. Well, our wish list, right? Oncologists' wish list. Can the cardiologists give us a score on what is the likelihood that these patients will get what you call torsades and will go into malignant arrhythmias? Is there a score based on genetics? Can you do a simple blood test and give us a score? And this is something that a lot of people have been trying to do. So this is the genetics of cardiac arrhythmias. SEN is the sodium channel. This is the typical sodium channel for Brugada syndrome. Female sex is an increased risk factors. And the feeling is that based on your inheritance pattern for all these small nucleotide variants, you can tip a person into getting long QT syndromes, or you can have actually a very high penetrant big effect phenotype with a mixture of SNPs, and then you tip over. For people with drug-induced QTCs, they may have actually a low penetrant gene with a mixture of what you call SNPs, low penetrant alleles. And just the fact that you give them, let's say, ribociclib or classic, then they tip over. So the question is that if should we start screening for these rare penetrant phenotypes, like the sodium channels? If you give someone like that ribociclib, they'll probably go into torsades. Should we screen for all these rare diseases? Our main worry is actually for the third hit, and this is not it's not a trivial problem, because every time we put patients on all these drugs, we go a bit crazy actually looking at all the concurrent medications, and we keep calling the pharmacists, we keep doing all these literature searches, because these things can happen. This is a short review, a recent review by the Brugada family, and then they talked a little bit about Brugada syndrome, and it lists the whole challenges of genetics behind Brugada syndrome, where the typical gene, the SCN 5A, only represents 10%. And copy number variants for the sodium channels another 2 or 3%, and rare variants make up no more than 30%. So 70% are unknown. And what can you do when there's so much in terms of unknown? But there is a movement towards developing comprehensive genomic scores. And I thought I'll just spend the last 1 minute talking a little bit about this. There are commercial companies that are going into polygenic risk scores. Alicia is one of these companies. You can Google on the website. They specialize in polygenic risk scores and in data-driven cardiology. So, and they publish quite a lot of interesting articles. So this is some of their products. They have all these predictive modules for coronary artery disease, genetics, cholesterol, a lot of bioinformatics, very, very, very complex. Seka Kathirasan, he's from the Broad Institute. He's published many years ago on the polygenic risk scores for myocardial infarction. And he's shown that, people with monogenic Mendelian high-risk alleles, that you can actually select a group of people with polygenic risk scores with equivalent risk to these large single gene alleles, and that you will capture more patients, about 17% versus 2 in 100 for these things. And recently, another group just a few months ago has shown the use of polygenic risk scores for the development of dilated cardiomyopathy as well as hypertrophic cardiomyopathy. So these are not just Mendelian, they are on top of Mendelian. They're polygenic risk scores to tell you, the genes that stratify you into heart failure, dilated heart failure versus systolic heart failure. They follow the genes and the alleles that lead for Mendelian Holcombs. So this is something interesting. And I thought with this, and here I'm not an expert in this area, I'll be very happy to discuss, but it seems to me that if you were to ask an oncologist for their wish list, we just would like a score, who's going to get heart disease in 20 years, accelerated coronary artery disease, who's going to get Holcomb, who's going to get cardiomyopathy, and who's going to drop dead when you give them classic. So with that, thank you very much.
Thank you very much, John. I think that was a very clear presentation, and I think your wish is hopefully something we can match, and we will try to keep those questions coming, and we'll answer them at the Q&A session a bit later. So we'll move on to the next speaker first. Next one will be by Dr. Juan Lopez Matei. He's a co-director and co-founder of Cardiac Radiology Services, University of Texas at MD Anderson Cancer Center. He's unable to join us today and sends his apologies, but he's prepared a lecture. I saw the slides, it looks pretty interesting. So without further ado, we'll play his slides right now.
Hi, My name is Juan Lopez Matei. I'm Associate Professor of the Department of Cardiology and Thoracic Imaging at the University of Texas MD Anderson Cancer Center. And I'm going to talk to you today about radiation therapy. What is the influence of treatment on patients' cardiovascular system? So let's start with this case. This is a 52 years old female with history of Hodgkin lymphoma, status post high-dose radiation therapy with 40 grays to mantle 20 years ago. She also received chemotherapy and was referred for further evaluation given rapid progression of shortness of breath and chest pain. Here is her echo. You can see that the systolic function looks normal visually, at least in this imaging plane. The mitral valve looks thickened but opens well. The aortic valve is not that well visualized, so we decided to focus a bit more on it. When we go closer, you can see that it's significantly thickened. And if you also notice, the aortomitral carton is also significantly thickened, which is our findings of radiation-induced valvular heart disease. This is the short axis, the basal short axis, and you can see that the valve looks opening a little bit, but it's significantly thickened and calcified. And in this plane, sometimes depending on where you're cutting, the valve might look that it's open more than what it really is, depending on the plane. So it's not really reliable to do a planimetry on a transthoracic to assess for AS severity unless you're using a biplane method of acquisition. Here, the velocity of the aortic valve, you can see that the velocity almost gets to 4, but not quite, but it almost gets to 4. It's very close, but the issue here is a technical issue, because if you look at the 2D image upwards where you see where we get the velocity, you see that the green line is not aligned with the blue line. So the transductor is a little bit perpendicular to the flow of the aortic valve. So that was corrected, and when we did that, the velocity was 4.3 meters per second. So this is really the real deal, significantly severe aortic stenosis. The patient got an MRI, and the valve area by MRI was 0.7 or 0.8 centimeters square. This is in millimeters square. The centimeter square will be 0.8. And also in MRI, if you notice to your left hand, this is the cine still frame of a cine image, and to the right hand, you can see that there is some enhancement in the inferior segments, which can be seen in aortic stenosis, and radiation treatment can cause myocardial fibrosis. So this patient got a coronary angiogram after the previous echo that I already showed you, and patient had non-obstructive coronary artery disease. So it was decided that the symptoms were coming from the severe stenosis of the aortic valve. So patient got a TAVR, and you can see the prosthetic valve now opening and closing nicely. And patient after this procedure have been doing very well. And you can see that the velocity is normalized because of the TAVR. So this was a very good indication for TAVR. As for the risk factors for radiation-induced heart disease, it's important to understand the most important as anterior or left chest irradiation location, more than 30 grays in the mediastinum, less than 50 years, high dose of radiation fractions, lack of shielding, concomitant chemotherapy, cardiovascular risk factors, and pre-existing cardiovascular disease. These are important factors in assessing the possibility of radiation-induced heart disease. And if you look at the seminal paper by Dr. Darby in New England Journal of Medicine, you can see that in the 2000 the past 2 decades, the increase per grade of 7.4% will mean a percentage increase in major coronary events. So it's a linear relationship. The more radiation you get, the worse patients are going to do in regards to coronary events. So it's very important to keep this in mind. So radiation therapy, it can be atherogenic and cardiotoxic. And this is a great example, just showing, like, if you look at the lower panels, you can see that there's a coronary angiogram where it was called normal, no significant lesions or anything significant. But when this same patient got the CT, you can see that the lumen looked good, but there's some calcified plaques. And this is the strength of CT. You can have normal invasive coronary angiogram and still have coronary artery disease, because invasive angiography is just a luminogram, unlike CT where you are imaging the plaque. Then there's the calcium score, or the CAC, where you can quantify the CAC, and this is very prognostic, and it's actually a very important marker of prognosis. So you have to consider, when you are evaluating a patient, especially a cancer patient, previous radiation, just look at the previous CAT scan. And if you see calcification in the coronaries, that's something very helpful. And that can help to stratify, as we will see soon. So this is a work that I did at MD Anderson, where we just put together some cases where they got radiation therapy, so the treatment plans, and from the radiation doses of the treatment plans respective to each coronary region, we found that the doses were related to, or could predict, future calcification. So this is something that is actually very useful, because unlike other patients, in these patients, you can actually see the regions where they receive radiation, and then correlate clinically whether they're having their clinical manifestations in that same region. And we also found that diabetes was a predominant factor that dominate also the presence of calcification in the coronaries. And this was a very interesting study, where using the treatment plans from the patient that received radiotherapy to the chest, these were thousands and thousands of patients. They were able, using artificial intelligence, to separate by fatal and non-fatal cardiovascular disease using CAC, or calcium score, to show who will fare better and who will fare worse. And you can see that it kind of follows the traditional CAC scores, where 0 is the least risk, and more than 400 is a higher risk of having fatal and non-fatal coronary or cardiovascular events. So using artificial intelligence with the treatment plans, which are CTs, but low resolution CTs, they were able to prognosticate these patients. And this is a very nice review article by Melinda Tsai and group from Cleveland Clinic. And basically, it just highlights the complications related to radiation induced heart disease or radiation associated cardiac disease, where you have pericardial disease that you can see in echo and CT. You can have developed conduction system disease, vasculopathy, myocardial disease by meaning myocardial fibrosis, and valvular heart disease. And all these manifestations can be assessed by different modalities, such as CT, cardiac MR, and echocardiography. So it's important to understand the way the disease process happens and which modalities can help in identifying these complications. So how the aortic stenosis happens? So the aortic stenosis, or how the valve calcification happens in radiation-induced heart disease. So within the valves are composed of endothelial cells, where they have lamina fibrosa, spongiosa, ventricularis, and they also have these cells that are called the valve interstitial cells. And these cells are important in the pathogenesis because when you, this was a basic science study where they used a human aortic valve, and they showed that when you either irradiated the valve or you did samples of tissue and valve that were stenotic, when they look at this BMP2, which is the bone morphogenic protein 2, so this protein is expressed, and it's in the red speckles that you see in stenotic and irradiated valves. And when you look at it, it is expressed very well in those, because the hypothesis that they proved here is that there's that the radiation induces osteogenesis in aortic valve interstitial cells. So these interstitial cells, they get calcified, and hence cause the stenosis, the stiffness and stenosis that happens to the valves in radiation-induced heart disease. And let's talk about aortomitral curtain's thickness. So this is a structure in the heart where the LVOT meets the mitral, the anterior leaflet of the mitral valve, and Melinda Desai and group have shown that if the thickness value is 0.6 centimeters or higher, this predicts increased mortality. And this study was done in patients that underwent cardiac surgery and had radiation therapy. And when you look at all the different variables in table 5, the hazard ratio for aortomitral curtain thickness was very high compared with Euroscore, and it was significantly predictive of decreased survival in this cohort of patients that underwent cardiac surgery. And you can see the curves, how they separate. By having a higher aortomitral curtain, higher than a median, patient had definitely less survival. So this is a very important parameter to pay attention when you're looking at the echo, to measure the thickness of the aortomitral curtain in patients that receive radiation therapy. And looking at outcomes, long-term outcomes of patients that receive mediastinal radiation and associated severe aortic stenosis that undergo valve replacement, you can see by the graph here presented by this group that patients that underwent radiation therapy, they do worse, and they have a higher mortality compared with patients that didn't have radiation therapy to the chest. And so replacing the valve is not the only issue that needs to be taken care of. Certainly radiation therapy causes injury to the heart and other substructures, and likely that's the explanation why, you know, it's not only a disease of the valve, but it's a disease of other structures of the heart. And this is a study of our center where we compare patients, cancer patients that did not receive aortic valve replacement with the patients that receive either TAVR or SAVR. And this, in this cohort, we include the patient with radiation therapy. And you can see that even in cancer patients, if you don't replace the valve when they need to, they're just going to do poorly. So in this case, the numbers were small, so there was no significant difference between TAVR and SAVR. But the main point is that we have to do every effort, of course, depending on the patient prognosis from the cancer standpoint. We have to make every effort to offer life-saving therapies to our cancer patients. And in this interesting study, where they focused on outcomes of patients with severe symptomatic aortic stenosis after chest radiation, we can see here in the bottom of the diagram that when they did the adjustment using inverse propensity treatment weighting, they found significant differences between SAVR and TAVR, where TAVR with patients that got TAVR had better outcomes. So it's important to consider this in patients with radiation therapy. Prefer TAVR over SAVR by this study. And this is a very busy slide, but summarize the consensus statement document on multimodality imaging for patients that receive radiation therapy. So basically, the main recommendations will be to get a baseline echo before patient is exposed to chest radiation therapy. Then after they receive radiation therapy, an effort needs to be done to do a yearly targeted clinical history and physical examination. And when there is signs and symptoms that are suggestive of pericardial disease, valvular heart disease, LV dysfunction, coronary artery disease, carotid artery disease, conduction system disease, all of this will require some sort of evaluation, either by echo, CT, or MRI, depending on the findings. And but more importantly, if they are asymptomatic, which is a bit of a challenge, what we're going to do with these asymptomatic patients, it's important to consider doing an echo 5 to 10 years after the exposure, because at that time, that's where they develop the complications of radiation therapy. And consider functional non-invasive stress test or coronary CT. This is my recommendation in 5 to 10 years after exposure in high-risk patients. And then reassessed every 5 years. So there has to be some sort of follow-up and assessment, and this is a great opportunity to identify important disease in these populations. So that's all. Thank you for inviting me to speak to this great conference. Be well.
So we're going to move on straight to the Q&A session. I'm going to pass the mic over to Dr. Tan Li Ling, and she will lead some of the discussion. We've got the panelists here, and we have the Q&A button still on. So if you have any questions from the audience, please start typing in. So maybe I'll just hand over to Li Ling.
Yes, thanks, Edgar. Okay, good afternoon, ladies and gentlemen. I'm Li Ling, and I'm from the National University Heart Center, Singapore. So thank you for the organizers for putting together this wonderful session this afternoon. So we have, there's a question in the live Q&A section now. I see that Dr. Eric Young is actually typing the answer, but perhaps maybe Dr. Eric would like to answer this question so can we share with the rest of the audience. The question we have is, what is your protocol for steroid tapering in the treatment or management of immune checkpoints inhibitor myocarditis?
Yeah, it's a really good question. I just typed my answer. I think, you know, if it is myocarditis you're treating, you know, I've learned from my colleagues, and this is something I actually, this is one thing about the field. You have to rely on also national colleagues with their experience as well. Once we transition from methylprednisone to an oral prednisone, we usually try to be very rapid in our taper. I usually do about 10 milligrams a week, but I also do check troponins and ECGs and obviously assess the patient. There is one concern that we saw a very dramatic case of a patient who actually who was a kidney transplant, who unfortunately acquired a cancer urothelial tumor from a donor without knowing it, and got immunotherapy and then developed nephritis and was on steroids for a month. And then a week after coming off steroids, developed myocarditis and died in an outside hospital. So I think you still have to be very careful that you can't predict the immune system of what it can do once you start to titrate off. But ideally, you want them off of it as quickly as possible. There are still, I know, amongst my cancer colleagues, concerns for someone with active malignancy, ongoing steroid use. So we usually try to get them off of it as quickly as possible. There are other cases where you may need to be on a longer taper. We've had patients with severe myositis. Sometimes rheumatology will assess, our rheumatology colleagues will assess and do a little bit longer taper, but it's a very, it's an ongoing, discussion between subspecialties. But to answer that question, we usually try to do it as quickly as possible, but make sure the troponins and everything don't go up, start to rebound upwards, because that can be subclinically, a sign of maybe, myocarditis reoccurring.
Okay, so there are also some things in the literature that say that if patients don't respond well to your first-line steroid treatment, that we can add second-line agents such as MMF, mycophenolate. So, I mean, when do you start mycophenolate in this kind of patients?
The first line is obviously immunosuppression with steroid. It really depends, frankly. This is the challenging part. It depends on how clinically the patient appears. I think that, it's really dealer's choice because there are no randomized controlled trial data to say what's better. Mycophenolate, antithymic globulin. There's really, when you have someone with a high likelihood or a confirmed diagnosis of immune checkpoint inhibitor myocarditis, there are three major mechanistic things you are trying to do. One, you are trying to reduce inflammation, and that's what, and cardiac inflammation, that's what the goal of steroids are meant to do. But then also you want to remove T cells from the myocardium. And that's where you can use any of these medications. At UCLA, since we are a big cardiac transplant center, our cardiomyopathy colleagues are very comfortable with ATG and thymocyte globulin, and sometimes they will also use mycophenolate. But it's really just depending on the attending and how they use it. Also, since immune checkpoint inhibitors have about a half-life of about 20, 30 days or so, also you have to ask the oncologist, do you think we also have to take, plasmapheresis may also be considered as well, to take the drug out of the system if they're always worried about its causing. Sometimes these drugs will, the effects these patients can present months after treatment, so that may not be an issue. So you have to kind of look at the timing and decide when to escalate. It really just depends on, frankly, how sick the patient is. If the patient continues to do worse, if troponins continue to climb up, they show signs of cardiogenic shock, then we will usually escalate to second or third line therapies. Abatacept is also, there's a lot of excitement for that, although it's really been shown in, there was some case reports in the, a New England Journal talking about effectiveness, but that's also, hopefully, that will be a randomized controlled trial in the United States at some point in time. And finally, someone talked about the prospect of re-challenging. I don't think that is really routinely done. It really depends on, frankly, just the prognosis of the cancer. If there really is no other option, and this is an end stage, and I think if the patient understands the risk benefits, then I think that you can, frankly, it can be done. I have personally never done it or advocated for it, but most of our cancer docs will probably never use it again from that standpoint. So.
Okay, great. Thank you so much. There are some more questions in the Q&A section. So there's a question from Dr. Chow. He has asked, how should oncologists and cardiologists collaborate? And is there a value to have a common management pathway? So perhaps can we get one of the panelists, one cardiologist and also one oncologist in our panelists to answer this question? So can I maybe get Dr. Chong Jun Hao to answer this from a cardiology aspect?
Sure. Yes, that was a really interesting question. Thank you for that. I think that, it really is a multidisciplinary approach that we should be taking from our three esteemed speakers, from both the oncology and the cardiology side. It's shown that there are domain expertise on both sides, and then there's the overlap in the middle. More and more so with electronic medical records, there is the option now to actually have automated pathways, almost like a tick and flick, checklist that can be accessed by both parties. And certainly in my personal practice, I depend very much on my oncology colleagues for sending the referrals our way. And then they also would appreciate sort of an open kind of path of communication where you're easily approachable and contactable. Because, with these patients, they can sometimes deteriorate quite quickly, and it's important to be prompt and accessible in your practice. That would be what I would say from my own personal practice, and keen to hear from our oncology colleagues on how we can collaborate with them better.
Okay, thank you, Dr. Chong. And perhaps maybe we can get Dr. Benjamin Chua to give us the oncology point of view or perspective.
All right. I think the first thing to do is to, first of all, identify which are the patients that are more important for us to collaborate, rather than to include all the possible patients that may get affected by our oncology drugs, purely because all our drugs will affect the heart. But there are groups of patients that we owe a duty to, especially if supposing the aims are cure. So for example, we are talking about lymphoma patients where they have had cardiotoxic drugs, along with cardiotoxic radiation, and then along the way, including the breast patients who who have hormone blockade, and all these all increased risk of cardiac toxicity in the future. The main issue really is who follows up and who owns this patient. Because 5 years down the road, 10 years down the road, the oncologist will say you're cured. And the cardiologist, because it's more a preventive thing, don't see them that often. These are the group of patients that we should pay particular attention to. And at the present moment, this is where I think we are lacking. The whole talk about all these targeted therapies causing all these side effects and everything else, we must remember that the majority of them are palliative in nature. And therefore, even if we can give them a bit more mileage, the mileage isn't exactly like what we're going to do for the patients that we can cure. So this is where I think we can work harder.
So, Dr. Chua, so basically in your practice, are you comfortable in actually following these patients up in your care since you have already established such a good relationship with them? Are you comfortable in taking care of their cardiovascular risk factors? Or would you then transfer these sort of preventive medicine care to their primary general practitioner, or you will refer them to your family cardiologist?
So the comfort level is determined basically with the services that are available. If there is indeed a long-term service that will look into all this issue, we'll be happy enough to pass the patients over, especially if we think that they are cured. But more so at the present moment, we find that the patients will either end up with a general practice service where the GPs are just doing the routine things, and they represent a higher risk group. If not, we send to cardiology, but cardiology, those who are not really included for onco-cardiology will be thinking, I'm not sure what else I can contribute to this. So at the present moment, based on the services that are available, we actually do follow them up and follow them up for life, provided we outlive them.
Okay.
Yeah, if I could just add to that, thanks so much, Dr. Chua and Dr. Tan, for your insights. If we can add some perspective, this is not just a rare issue where you get a rare complication from chemotherapy. The global in Asia, we account for about 50% of the global burden of cancer, and that would be an incidence of 5.3 million by 2030. 5 to 10% of these patients will get cardiovascular complications, and they're expected to develop that over the age of 50 for the next 10 years of their life. So given that we have this opportunity for this medium where we've reached out close to 400 people, oncologists, cardiologists, other specialties, trainees, and primary practice physicians, I think it's important to raise the point that it is a collaborative effort. We are all cardio-oncologists when we look out for the patients. I particularly like the National Comprehensive Cancer Network ABCDE framework. It's not hard. Just assess their risk. Consider aspirin, particularly for primary prevention. B, for blood pressure. C, assess for cholesterol levels. D, for diabetes, the dosing, and E, for exercise and other types of imaging like echo and obviously ECGs. And when we can, come together like this, we can pick up deterioration in patients. I think Dr. Yang had mentioned the Cardinali study back in 2010 in his talk as well, where it was shown very clearly that if we delay diagnosis of cardiomyopathy secondary to anthracyclines, for instance, the patients actually don't respond. So the longer we take to initiate prognostic heart failure therapy, the less likely the patients are to respond. So I think we owe it to our patients to work together as a team, whichever our role is, whether in oncology or cardiologist or the primary physician or other members like allied health professionals, the multidisciplinary team. I think we owe it to our patients to work together and really have a multidisciplinary approach, a low threshold to look out for their symptoms. Thank you.
Thank you. I have a question for Dr. Francis Chin. He's a radiation oncologist. So Dr. Chin, basically what I'd like to know is because we cardiologists at least are not very familiar with all the different kinds of radiation therapy techniques that you have, especially when there have been vast improvements in the techniques. So perhaps we do know that radiation-induced heart disease usually happens decades after they get exposed. And then now that with there are improvements in all the techniques, what should we then look out for? Or is there any particular regimen that we should be a bit more careful or more wary if we know that the patient sitting in front of us has been exposed that kind of regimen?
Okay, so thank you very much for inviting me. a lot of, I think there's been a lot of awareness now, particularly and about the role of after you had radiation to the heart, and a lot of data has been accumulated. Since the publication of the Darby paper showing the linear dose relationship of dose versus myocarditis, we have actually given ourselves the mean target dose of less than 5 grays. So the ones where you actually would be more worried about is when the machines were not so advanced. I would say we had a big technology advance. You know, computers have advanced a lot, so have machines. So back, if anyone has been treated before 1980s, usually they would be treated on what we call conventional treatments. From the 1990s onwards, a lot of all the IMRT, VMAT, IGRT were developed. So we were able to so-called curve the dose and reduce the doses to the heart. And the radiation oncologists are quite aware nowadays that it is very important for us to outline the anterior coronary artery, and we avoid dose to that, and we avoid doses to the heart as well. And we have the technology nowadays to avoid it. Hopefully, with this improved knowledge, and the improvement that we know that with concurrent chemoradiation and anthracyclines, which are not avoidable in a lot of breast cancer, the only way we can actually reduce the heart failure rates is actually to avoid doses to the heart. So hopefully we will not see a big wave of cardiac disease from people who are treated from the year 2000 onwards. That's when I think a lot of the local centers, and depending on when your country switched, because after that, a lot of the machines use VMAT and RRT as a standard, and it will keep on getting better and better. Yeah.
Okay. And who do you leave it to screen for cardiac complications?
Yes. So I sort of alluded to a question, and there was a very good question asked. I think we can do better in terms of the coordination, because in the early days, we were more concentrated on actually treating the patients. But I also do a pediatric oncology. So I realized, a lot of the patients live longer and longer, especially for the young breast patients as well. And we actually can do better in terms of tracking and their heart disease, doing echoes. We tend to see them, and the ones which have lymphoma, we come back and we do breast cancer screening for them. But again, this is because of our bias as oncologists. We think of the second cancers, and as radiation as well, we always think of the second cancers, but there's always a silent comorbidity of heart disease, which we often send to just our cardiologists. Yeah, so there's not a systemic national screening program for all these people, for cancer survivors. I think a lot of work needs to be done, and a lot of work is being done in KK, in SGH, in NUH. Yeah.
Okay, thank you very much. So there's also a question that we have here. Basically, increasingly in our echo labs, when the cancer patients come to us for routine sort of during treatment echo screening, cardiologists now increasingly do something called GLS, also known as global longitudinal strain. So cardiology side of things, we do know what GLS means, but maybe can I get the oncologist to comment on if they see this term GLS or global longitudinal strain in their echo reports, what is their reaction? Do they just brush it off, or they call someone for advice, or they just act on it? And what do they do when they see it? So perhaps if the oncologist, maybe Dr. Richard Quack, if you would like to comment on this.
Thank you, Li-Ling, for asking me to comment on this, and I'd like to thank the organizers for having me. The cardiology colleagues have been very good in the recent years explaining this concept of GLS to the oncologists, and increasingly it has sort of taken a more greater significance in addition to the LVEF alone. And I think they have done a great job trying to tell us that LVEF is one of the last markers to go. And if you wait for LVEF to drop, then things are probably towards the mid or later stage of developments already. So we are quite familiar, and we are looking for the drops in the GLS, the exact mechanics of which I'm not familiar. I usually see a picture and the measurement is done. And one of my first questions I asked is, should the number get bigger or should the number get smaller? Because it's a double negative. It's a minus 21 to a minus 19 or something like that. And I think in many ways the cardiologists have succeeded in that respect. I think just to add to that point, it is not just the value that's important. And increasingly, I'm made to understand that the cavity sizes, the ventricular cavity, the dilation of the heart, and those are maybe earlier signs or something that we should also look out for. And also increasingly the use of biomarkers, serum biomarkers like BNP and TROP-T, which may give us an idea that some kind of cardiac inflammation or some cardiac event happening in the silent. And so I think that increasingly the cardiologists, also the oncologists are being made to understand these concepts in a very comprehensive way. And on that note, I'd just like to add on to the earlier question about the screening. I think one of the aspects that the oncologists face is that after the treatment, we are also very worried about relapses. So your attention is actually focused on the relapse. And if you don't see leg swelling, the patient complaining of breathlessness or chest pain, you sort of brush it off a little bit and you try to focus on the relapse. Your scans and your investigations are done in that respect. And so maybe, I don't know how this can be done, but maybe more attention or more focus, more awareness may go into the fallout, the cardiology aspects of things, into the toxicities, because we need to get past the relapses before we can get into the long-term survival and therefore the toxicities. And so at various stages, the challenges are also a little bit different.
Okay, thank you very much.
I do have one question. If there's time, maybe I'll post it at the end or something.
Sure, no problem. Okay, I have one question here because we are already running out of time. Can I pose this question to Dr. Ching Min So Dr. Ching, I understand that you specialize in heart failure patients. So can I get your opinion on, from a heart failure specialist point of view, how should we manage such patients, especially when they have cardiotoxic complications while on chemotherapy?
Thank you, Ling, so much for the question. So I suppose you're referring to patients essentially who have documented decline in LVEF, mainly asking about the HFrEF patients, right?
Yes.
So from my personal experience, I find that these patients can tend to be quite sick, meaning to say very often we see them when they present with clinically quite advanced heart failure, meaning to say that we probably lost out a lot of opportunity time in terms of preventing them from going into clinical heart failure, as well as from them deteriorating along the clinical stages. So in terms of the medical therapy that I would give for the HFrEF patients with chemo-induced non-ischemic cardiomyopathy, I think they're quite similar to the standard of care that is being recommended now for all heart failure patients, which essentially are the 4 drugs, beta blockers, ARNI or an ACE, SGLT2 inhibitor, or a mineralocorticoid. I don't think these patients are treated any different from the other non-ischemic cardiomyopathies. But since I have the mic now, actually, I would really like to ask Dr. Eric Yang if he would comment if he would start a heart failure therapy in an asymptomatic patient with uptrending biomarkers. And if he would, is there a cutoff in terms of the biomarkers that he would use?
Yeah, so thank you very much, Dr. Min, for that question. I put that also in the comment. I think there are 2 groups of HFrEF patients, and I think this also elucidates, I think, the elusive mechanism of LV dysfunction. I think a lot of us as cardiologists and heart failure specialists always associate a reduced ejection fraction with, cardiac fibrosis and advanced stage, non-compliant left ventricle. And that's the kind of therapies that were studied, like with neprilysin, valsartan, and some SGLT2 inhibitors. I think with those people that present with decompensated advanced heart failure, I think those medications we extrapolate to use if they can tolerate it. However, I would say that I was saying that how a lot of immediate patients who have undergone anthracycline treatments can present with depressed ejection fractions and be asymptomatic. Those are the kind of the phenotypes that you have to be careful about, because 1, they're not clinically decompensated. They don't have high filling pressures. I have several young cancer survivors in my group. Just for fun, I checked a BNP level on them, and they're 10. They're lower than mine probably, and those are people that probably, frankly, can't tolerate something like that. If you look at the Paradigm trials, you had to have symptomatic heart failure. You had to have elevated, pro-BNP or BNP levels. So I would probably not, I would use more traditional kind of other, less potent beta blockers and ACE inhibitors. And a lot of these are younger or younger adults or adults that don't have high blood pressure. They don't have a lot of room that can tolerate these medications as well. So, I would start them on low doses and see if their ejection fraction improves. And if it does, then I probably wouldn't escalate, as I would probably shy away from some of the later, more modern, like SGLT2 inhibitors and ARNIs from that standpoint. But I still would try a challenge of beta blockers or ACE or ARB, depending on how they do. But I wouldn't necessarily do the quad pillar for the immediately newly diagnosed low EF unless they do present, as you mentioned, a decompensated symptomatic evidence of, congestion. Those are the ones I definitely would, but frankly, more often it's at least in what I come across, it's the asymptomatic low EFs in the 40s, and they feel fine. They can do marathons, they can exercise, and they feel okay. But if you don't do anything about it years down the line, then they will develop problems. And we unfortunately do catch a lot of people who never got surveillance late, with advanced heart failure. And by that point, like you said, it's already in a sense too late in terms of reversible.
Okay, thank you for that. Okay, so I have a very last question to ask Dr. Suan Hong. Basically, we have a question from the audience who has asked, would you start cardioprotective drugs when there is only a relative drop in GLS by more than 15% without a change in LVEF?
Oh, yeah, okay. Thanks for the organizer for inviting me to be part of panelists. Personally, can you hear me?
Yes, very clear.
Because I've been muting myself. Personally, I work very closely with the oncologists, as you have seen, and people like Richard and Ben have been well taught on GLS over the years. And we communicate very closely with them on what are the implications, because as I taught them, we don't just look at EF as the old way from back in 2010, and there's not been any consistency in the guideline on what constitutes significant. What's significant in the guideline may not necessarily mean that it applies to the patient. So we look at overall the heart performance, not just the EF, but the LV size, the mitral regurgitation, because that reflects the hydration status. We look at the GLS, we look at these biomarkers, and if any of this shows a decline, not even 15%, we will actually raise the yellow flag to the oncologist. We'll give them a call and say that I have these concerns and that concerns. I may not start the drug at that point in time, but I might ask to screen the patient a bit earlier than usual. And if there's further decline, then we'll not hesitate to start. Like I said, every patient, we can't possibly have every patient's baseline data because you can't screen everybody. But if there's any patient after the initial screen, we find that there's slight change or something that's just not quite right, we will ask to see the patient a bit earlier. And in addition to that, I just want to say that not all decline in heart function is really due to drugs. All right, we must keep that in mind. It can be due to sepsis, due to a variety of conditions. Even hydration status will change your readings. So if the patient has decline in heart function, we go back to look at data, like some of these cases, even before we start screening them or giving them chemotherapy, I will ask the oncologist for the baseline data and look at the degree of calcification in the background in the PET CT, because all these informations are there for you to take advantage of. And those people with high risk markers, when you look at their baseline CT, you might want to screen them more. So we can't screen everybody, you can't save everyone, but we got to be vigilant with all the information that we have on hand.
Thank you very much for your opinion. I'm so sorry, there are still a lot of questions which we have not been able to answer, but we are really running out of time. So I'd like to thank everyone's participation and all your expert opinion, and I'll pass the mic back to Edgar.
Thank you, Li-Ling. Amazing. We still have about more than 350 people still with us. It's almost spent 30 minutes past time. So thank you again for for really joining us. Really appreciate, especially our expert speakers, Dr. Eric Young, John, and Dr. Juan. He couldn't join us, but certainly I hope you enjoyed his lecture. And I also like to thank all the panelists who spent their lunchtime with us today. And of course, all of you who really stood out for 90 minutes solid with us. And I just wanted to tell you that there's this QR code that you can scan if you want to get your certificates. And before I end, just one final slide for our next webinar. So if you are interested in our next theme coming up will be on geriatric cardiology for 2021, our final webinar. So I hope you could also join us if you have some time. So thank you very, very much again and have a wonderful weekend. Thank you and bye-bye.